With dysrhythmias, do not be intimidated by your lack of experience with this. If you're not doing this at work, it's fine. You don't need to be really a master on this. For exam purposes, we'll only use the strips that are available on your textbook, because a dysrhythmia can appear more than 12 different ways on a particular patient. It won't be the same every time. So it's not fair to use a strip from another textbook or from an actual patient. So on an exam, whatever strips are on your textbook are what you'll see on your exam, right? And over the decades, nobody has come back and said, oh, I got a test question on the NCLEX that wasn't covered in class as far as dysrhythmias go. So everything that's on the textbook has been enough for the NCLEX, all right? So we only want basic knowledge of dysrhythmias, how to care for patients who have dysrhythmias. First of all, this is not a rhythm class. Rhythm interpretation classes run for 8 hours a day times 3 days. That's for the monitor tech. So if you want to become a telemonitor tech, that's your class. 8 hours a day, 3 days. That's the class. We only have less than 3 hours, right? And for the nurses, it's a 6-week class. Plus you have homework to do before you attend class, so that's even longer. All right, so don't expect to become experts after we finish this class. I just want to set expectations clear. All right, okay. First of all, on the exam, so remember, exam 3 is not a cardiac exam. Are we clear? It's just one of the topics. All right, so don't go crazy studying this 100% of your effort, and then you discover it's not 50 questions. All right, so this will be probably what, 13, 15 questions, all right, on exam 3. Is that clear? All right. So there are 5 possible questions for each of these dysrhythmias. So first question is, I'll just put a rhythm strip on the question, and simple ask question is, the nurse recognizes this rhythm as which of the following? That's it. What does it look like? What does the rhythm look like? Number 2, what are the causes? Reason is not all dysrhythmias need interventions. Some of them just require identification and elimination of the cause. For instance, if the patient has PVCs, for instance, premature ventricular contractions, usually caused by smoking, coffee, some medications, right? So therefore, it doesn't require treatment. So we just need to identify the cause and then eliminate it. Then we get rid of the PVCs. Third is the easy part, which is signs and symptoms. What will the patient's manifestations be? It's easy because there is no dysrhythmia that increases cardiac output. They all disrupt the cardiac cycle. So therefore, cardiac output will drop. Do you remember signs and symptoms of heart failure? Because in heart failure patients, they had decreased cardiac output, correct? So will the manifestations be different here? Exactly the same as what you saw in heart failure. The severity, of course, will vary depending on what dysrhythmia is the patient having. Because some dysrhythmias are mild, some are harmless, some are moderately dangerous, some are fatal. Okay. Number 4, interventions. As I mentioned, not all dysrhythmias require interventions. When we say interventions, usually more than half the time they require medications. But as already mentioned, not all will require treatment. So therefore, the patient may just require a change in the therapy, or maybe the doctor needs to do a maneuver for a few dangerous ones. Okay, we'll talk about those as probably next during 1 o'clock, okay, during lecture. Number 5 is patient teaching. Of course, you want to make sure the patient understands what type of dysrhythmia they had and what the common causes are, so that they can avoid the cause, and then know what to do when the manifestations return. All right, so what are those 5 questions again on the exam? What does it look like? What are the causes, manifestations, interventions, pharmacologic and non-pharmacologic, and patient teaching? That's it. Okay. Let's look at the basics first. All right. So in the, I'll show you the illustration on the next page. We have 3 pacemakers. Now, unlike all other muscles of the body, wherein they rely on nerve stimulation in order to function, the heart is different. So there's some truth to what you see in Hollywood movies, wherein a martial artist punches somebody's chest and then rips out their heart, and you see the heart beating right outside the outside the patient's body and beating in the hand. It's not entirely accurate, but there's some truth to it, because the heart, even if the patient is brain dead, it will continue to function because it has its own action potential. Now, unlike skeletal muscles wherein they become useless once the brain ceases to function, have you ever seen a patient walking around who are brain dead? No, they can't, right? Because without nerve stimulation, muscles are useless, correct? So therefore, unlike the cardiac muscles wherein it can generate its own electrical impulse, therefore, it doesn't need the brain in order to function. So even if a patient is brain dead, the heart will continue to function because it has its own action potential. Does that make sense? Okay. So let's talk about that potential. So we've got 3 pacemakers. We've got primary, secondary, and tertiary pacemakers of the heart. The primary is the SA node. This is located in the right atrium. It has interatrial branches, meaning it will stimulate both the right and the left atrium at exactly the same time. It's capable of firing 60 to 100 electrical impulses per minute. The secondary pacemaker is the AV node. This is also known as the gatekeeper. I'll explain that term later when we get to the illustration. The AV node, being a secondary pacemaker, is also capable of firing electrical impulses. However, it can only fire between 40 and 60 impulses per minute. So yes, it can sustain life somehow, but not the same as the SA node. The tertiary pacemakers are the left and right bundle of His, or left and right bundle branches all the way to the Purkinje fibers, but they're not worth talking about because they can only fire 20 to 40 electrical impulses per minute. Now, is that capable of sustaining life? 20 to 40 beats per minute? No, so it's not worth talking about. Even if they're working, they're not going to keep any patient alive. So we're only going to prioritize the SA node and the AV node. Any questions so far? All right. A few terms here when we get to the next page. Depolarization is also called contraction. Repolarization is also called relaxation, meaning in depolarization, all this means that is that a cell, a myocardial cell, is already full of positive charges, meaning there are so much calcium, potassium, electrons inside that it needs to discharge that energy. When it does, it causes contraction, also known as depolarization. And then after that period, they go into relaxation mode, meaning they're absolutely negatively charged, and then they start to repolarize, wherein calcium and potassium channels start opening, and then those electrolytes start entering the cell, and they become repolarized again, ready for the next depolarization. You follow? Any question? Okay. As I mentioned, there are factors that influence the heart, although again, the brain doesn't need to control the heart, but the brain or the CNS can influence heart activity. For instance, sympathetic activity does what to the cardiovascular activity? Sympathetic. To stimulate or inhibit? It stimulates, right? What about the parasympathetic? Okay, it will do the opposite, correct? Okay, so some examples here, they will be mentioned again when we get to the dysrhythmias because these are identified as common causes of dysrhythmias. For instance, if let's say you drink a lot of coffee, you smoke, for instance, or these emotions mentioned here like exercise, anxiety, fever, these are all sympathetic stimulation, correct? Whereas some medications will also do the same. Catecholamine medications will have sympathetic effects, or they're also called sympathomimetic agents. Whereas if you have the opposite, which are the cholinergic effects or cholinergic medications or parasympathomimetic agents, occur with, let's say, resting or after a meal, for instance, or after these medications. All right. Where I'm not testing the ECG, I'm just going to explain how it works. So the ECG, also called EKG, whichever term, they refer to the same thing. This was invented by Dr. Einthoven. We'll look at a picture of the Einthoven triangle on the next page. Oh, it's actually here already. All right, so let's briefly explain this. This is not testable. I'm just trying to explain what you're looking at. So you have the heart there. Imagine you have somebody's head on top of that heart, and there are two lungs on each side. There's a right lung and a left lung. And over the corners where you see that upside down triangle, over those two top corners are the patient's shoulders. Okay, and then the patient's torso, of course, is where the heart is located. And then we've got the right leg and the left leg. All right. So when we say 12-lead ECG, which is the minimum standard in order to make a diagnosis of a abnormal heart rhythm. Now, this is different from what you see in telemetry floors. So who works in hospitals here? All right, so have you seen patients on a cardiac monitor? Yeah. Okay, so they only put 5 leads, correct? Yeah. On a portable box. Okay, so there are only 5 leads there. That is a limited view. So because it only has 5 leads, the most you'll see there is between 3 to 6 leads only, or 3 to 6 views. A 12-lead ECG has 10 leads or 10 electrodes, giving you 12 views. Now, how do 10 leads give you 12 views? Well, because some of the leads are bipolar. Look at the left arm. So the left arm lead carries both positive and negative poles. So therefore, they are called bipolar leads. Now, because of that, unlike the others, which only contain or carry either a negative or positive charge lead, because it's positive and negative, that will give you 2 views. Okay, so they will interact with another lead, giving you an extra view. All right. Now, what are you seeing here? So the electrical conduction pathway, if you think about it, starts from the SA node. It fires an electrical impulse, and then it will spread to the interatrial branch, which is located in the left atrium. It's an electrical impulse. Now, we cannot see electricity, can we? And you see, okay, the closest we'll see for visual representation is lightning, a lightning bolt. We've all seen lightning, right? So when you saw lightning, appear in the sky and then hit something on the horizon, did it take a long time? Were you able to time 1, 2? Were you able to do that? It was over before you even thought about it, right? It's that fast. So can you switch the light on for me, Ms. Lata? Did it take a long time? Probably not that one. But look at turn off that one, then turn on the right one. Did it take a long time for those two lights there to turn on? They turn on instantaneously, right? Together, because they're on the same circuit, right? Okay, thank you. So it's the same thing here. So when the SA node fires, the electrical impulse will reach the left atrium instantaneously, causing both atria to contract at exactly the same time. There's no delay. That's the same electrical impulse that will be transmitted to the AV node, and then eventually to the left and right bundle fibers, and then all the way to the Purkinje fibers, causing the ventricles to contract. Correct? So again, the same electrical impulse, same electrical current is passing from the SA node, firing here, transmitted here, transmitted down here. So will that take a long time? Just like when you flip on the light switch? No, it's instantaneously, right? But there will be a delay. We'll explain later when we get to the waves and complexes, right? Now, since the pathway is literally from the right shoulder to the left leg, that's the direction, correct? So from here down here, because the heart is tilted, it's in the center, but it's tilted to the left side. So the electrical current literally travels from the right shoulder all the way to the left leg. Now, you'll see I'll show you a 12-lead ECG shortly. So you'll see only the left leg is mentioned here. The right leg is only a ground lead. It doesn't carry any electrical pole. This is now the placement of your ECG. Now, regardless of the type of brand of ECG equipment you have, they will all have 10 leads. So there are 6 chest leads, and then there are 4 limb leads. Right arm, left leg, right leg. Again, right leg is the ground lead. It doesn't contain positive or negative. Let's go. There are 6 leads placed on each sternal border. Second intercostal space, so that's B1, B2, then B3 will follow right below the B2. That's about still left sternal border. Then B4 will follow mid-clavicular line, B5 right next to it, and then B6 is not shown here because B6 will be in the mid-axillary line, about 6 intercostal space. So that's the placement of the 6 leads. Now, how do these matter? Now, if you think about it, the heart is in the center and you have positive and negative charge leads placed strategically around the heart. So this will give us 12 different views. Think of it as the best analogy is you have 12 different photographers taking pictures of the heart from a different vantage point. Okay, so therefore each photographer is looking at one is taking a look at it from the right shoulder, another from the left shoulder, another from here. So you have a 360, literally a 360 view of the heart. So this helps the physician see where is the anomaly occurring, which coronary artery is blocked, where is the ischemia happening. Okay, so without a 12-lead ECG, it's impossible to make a diagnosis. So when we have the portable ECG, the cardiac monitor, which only has 5 leads, that is a limited view. So the doctor will still order a 12-lead ECG. So let's look at what it will look like. So this is an example. But this is a 12-lead ECG. You'll notice that they look different depending on which lead you're looking at. Now, almost all, if not 90%, if not all of the strips you'll see on your textbook on this chapter are usually taken from lead 2. Why lead 2? Because you go back to the Einthoven triangle, it's parallel to the electrical conduction pathway. So again, the pathway is running from the right shoulder all the way to the left leg in that direction. Now you'll see lead 2 is looking at the picture of the heart from this angle. So it's parallel to the conduction pathway. So this photographer here, this lead 2, is looking at it on the same direction as the normal electrical conduction pathway. So it's almost perfect. However, lead 1 is looking at it from the top. So therefore, lead 1 will have a different view from where it's looking from. So is lead 3. And then same thing for leads 4, 5, and 6. So when we go here, so that's why this is lead 1. So as far as lead 1 is concerned, this is how the electrical activity looks like from where it's standing. Then lead 2, this is what it looks like. Lead 3, since it's on the right side, looks different, right? Look at lead 2 and lead 3. Completely different picture. And same thing for B1, 2, 3, 4, 5, 6. And then you have the AV, now right arm. That's what it looks like as far as the right arm is concerned. Left arm resembles lead 2. Okay, it's similar. Left arm. Then AV foot, this is AV left foot. There is no AV right foot because obviously there's no lead on the right foot. So we only have and so on. You have V1 all the way to V6. Okay. Any question? So this is what you're looking at. So that's why it looks different. It's because they have a different vantage point. Now, as far as the changes go, so let's say this patient has any abnormalities in the ST and T changes, depending on which lead it appears, the doc gives the doctor an idea about where is the heart attack or the ischemia coming from. Is it posterior? Is it on the base? Is it on top? Is it on the right side? Is it on the left side? Does that make sense?
Yeah.
Okay. So let's not concern about that though, because that is the doctor's job. We will not be doing that diagnosis. Are we clear? Any question about where to place it? Because you may be asked on the NCLEX about where to put the leads. Any question?
Yes.
Okay, so this is your answer. That's where you place them. Yes, when we say leads, we're referring to the electrodes. Okay, so how many electrodes are there on a 12-lead ECG? 10 electrodes, giving us how many views? 12 views. Okay, not 10 views, we'll get 12 because one of them is bipolar lead. All right, let's look at now what what are the waves and complexes representing? So what you're looking at here is a PQRST. This is one cardiac cycle, meaning this is one heartbeat. First of all, let's look at what the papers represent. So on an ECG paper, you've got horizontal lines and we've got vertical lines. Again, you've got horizontal lines, vertical lines. Horizontal lines represent time in seconds. You'll see that there are small boxes, and within those, there's a big box, correct? Okay, so you've got small boxes here, and you've got big box. If you count, there are 5 small boxes and 1 big box. All right. I'll explain the significance later. So what does the horizontal axis again represent? Time in seconds. What about the vertical axis? This represents voltage in millivolts. Okay? The vertical axis measures voltage. How many voltage is it in millivolts? We also measure it in millimeters. Okay, so one big box, for instance, is 0.5 millimeters. Okay, in height, literally millimeters. You know, in metric system, okay, millimeters. Or in voltage, that's it's also in millivolts. Each small box, as you can see here on top, measures 0.04 seconds. One small box is 0.04 seconds. So therefore, one big box, since it has 5 small boxes, one big box measures how many seconds? 0.2 seconds. Okay. Again, one small box, one of these small tiny boxes here, measures 0.04 seconds. Multiplied by 5 equals 0.2 seconds. All right. You follow me so far? Okay. So now let's go to what does each wave and complex mean? Now, I won't follow the order here because I want to go with the PQRST. So it's easier to discuss it based on the sequence. Okay, so P, Q, R, S, and then T wave. For today, we will disregard the U wave because we rarely see a U wave. U waves usually appear when you have the potassium. It's more like an anomaly, you know, like we see it. I'd say 99% of the time you won't see a U wave. Only about 1% of the cases you'll see a U wave appear, but it's not really that significant. Okay, let me put it that way. So what does it mean when we see a P wave, a QRS, and then a T? Okay, so let's discuss each wave and complex. Start with a P wave. Here's your P wave. Thank you for reading. Meiji.
Therefore, the P wave representation of polarization. It is number 2.5.
All right. So therefore, based on that definition, 2 things happen when we see a P wave. So when we see a P wave, we know 2 things happen. What is one of them? So based on the definition, what is a P wave? Electrical impulse started where? Okay, so when you see a P wave, that means the electrical impulse was initiated by which pacemaker? The primary pacemaker. Okay, so do we want to see a P wave? Yes, for every heartbeat, we should see a P wave. No P wave, we start to worry. Okay, so when we see a P wave, that's always nice to see. It's a nice sight to behold. Oh, we see P wave. That means the electrical impulse started from where? The SA node. It's a normal impulse, okay, generated by the SA node. And what's the other thing that happened? Since the electrical impulse spread through the atria, and therefore the P wave represents what? What's another term for depolarization? Contraction. So we know that the both atria contracted. Okay, so 2 things again. When we ever see a P wave, what are those 2 things? Atria contracted and that impulse came from the SA node. Okay, very good. So that's the P wave. Now we measure the P wave and it says there it's less than 3 small boxes, correct? Because each small box is 0.04 seconds. So if it's less than 0.11 seconds, 0.11 seconds or less, so that means it's about less than 3 small boxes, correct? So here, is it less than 3 small boxes? To measure, by the way, we imagine an isoelectric line. What is an isoelectric line? It's a imaginary straight line from which every wave and complex leaves and returns to. Okay, so this one doesn't count because this is drawn by somebody. So let's look at an actual one. I'll go back to this page. Look at this one. If you look at it, does the isoelectric line fall on a solid line here? Not at all. But can you imagine a straight line from which every wave rises and falls back into? Yes, there's a somewhere here, correct? So the wave, for instance, the P wave starts here. We know it starts here because it left the isoelectric line. And then where does it end? Right here, where it returns to the same isoelectric line. And it'll be the same for the Q, R, and the S waves, and then the T wave. Right? So there's some imaginary straight line there from which all of the waves complexes left and returned to. All right? So we measure the P wave from here, where it left the isoelectric line, to where it returned to the isoelectric line. So therefore, we can say that atrial contraction lasted how long? Less than 0.12 seconds. Okay, so it's about 0.11 seconds. You follow so far? All right, so that's the P wave. Next, let's go by the order by which things happen. So instead of looking at the QRS, let's look at the PR interval first. So here we started with the P wave and we know what the P wave represents. Let's look at the PR interval first, this one. Thank you for reading, Ms. Duff. PR interval.
PR interval is measured by from the beginning of the P wave to the beginning of the QRS. And represents time where no inflammation and arterial depolarization and conduction through the AV node or ventricular depolarization. In adults, the PR interval normally ranges from 0.12 to 0.20 seconds in duration.
Okay. So the PR interval is measured from the time of atrial depolarization, right? So it measures the P wave itself up to right before the ventricles contract. Ventricular contraction is the QRS compound. So it measures from here to here, right? That's your PR interval right here, PR interval. So it says there on the definition, it represents time again, correct? The duration, how long does it take for the atrial to contract? And then for that, the same impulse to reach the AV node, and then before the signal is transmitted to the ventricles, because the impulse is transmitted here, correct? So therefore, let's go back to the electrical current, the lightning bulb. So if it's an electrical impulse, will it take a long time for that impulse to leave the SA node, reach the interatrial branches, and then reach the AV node and pass through here? Will it take a long time?
No.
Not at all. It will go straight, just like the light turning on, correct? However, did that happen? Did the electrical impulse go from the SA node straight down to the Purkinje fibers? It did not. So the proof here is the PR interval. Okay, so there is a delay, correct? Because if you think about it, it's the same electrical impulses causing the entire heartbeat. However, if that happened, then the QRS and the P wave will actually happen at the same time, right? If you think about it. But is that what happened? No. There's a moment here before the ventricles contracted. So therefore, is it really instantaneous? Is the electrical current instantaneous? It was not. So this is the delay which is made possible by the AV node, because the AV node, of course, it received the electrical impulse right away, right? I mean, it's a freaking electrical current. So yes, it received it. The AV node received the impulse from the SA node. However, did it transmit it directly? No, it delayed it by how long? How long is the PR interval? 0.12 to 0.2 seconds. So that is a delay. This is what we mean by the AV node performs a very crucial function. It is a gatekeeper. It knows that if I transmit this, what will happen to the timing of the contraction? Will there be a delay between atrial and ventricular contraction if it did not delay the transmission? No, the atria and the ventricles will end up contracting at exactly the same time. So is that good? There will be no blood movement, right? So the heartbeat should be atria first and the ventricles next. So atria contract, pushing the blood into left and right ventricles, and then after that, ventricles contract, and then the right side pumps it to the lungs, the left side pumps it to the aorta. You see what I'm going? Okay, so therefore, do we want to see a PR interval?
Yes.
Yes, we want to see a PR interval. However, will time ever wait? Will time ever be longer or shorter? Time. Will 1 minute be longer than another? It'll be the same. So let's say in 60 seconds, since this is one heartbeat, PQRST, that's one heartbeat. Okay, you see PQRST. So therefore, if you have 60 to 100 beats per minute, and that's the appearance on the ECG, imagine what the PR interval will look like. If let's say someone's heartbeat is 200 beats per minute, will it look like this? No. What will happen to the PR interval? The higher the heart rate, the narrower or the shorter the PR interval will be. So what is the implication there about cardiac output? Is there time for ventricular filling?
No.
Therefore, what can you say about tachycardia? What happens to cardiac output then? It drops, right? So any heartbeat, either too low or too high, and especially if it's too high, the higher the heart rate, then the lower the cardiac output, because the PR interval narrows. So therefore, think of it, what's happening during the PR interval? And where did that blood go when the atria contracted? So therefore, what's happening here? Ventricular filling, correct? So the ventricles are filling with blood during this entire period, you agree? Okay. And then as soon as the ventricles filled with blood, then the AV node transmitted the impulse down to the left and right bundle branches. Do you appreciate the implication? All right. So here we have SA node fired. What appeared on the ECG? P wave. So you saw the P wave when the SA node fired the electrical impulse. The P wave appeared, correct? Causing the ventricles to contract, and the PR interval allowed A delay, correct? The AB node, yes, it received the impulse from the SA node instantaneously, but did it transmit it? No. How long did it delay it for? 0.12 to 0.2 seconds. It chose to delay. No, I won't transmit. Yeah, I got it, but I won't transmit it yet. I'll wait until that blood fills here. For how long? Again, 0.12 to 0.2 seconds. And as soon as that happens, then here you go. Okay, they transmitted the impulse, and now the ventricles contract. So ventricles contract. What will appear on the ECG? On the monitor? The QRS complex appears. Okay, so you'll see the QRS complex, which represents what? Thank you, Mr. Garriston. Okay, so let's measure this. All right, it's less than how many seconds? And therefore, the whole duration is less than 0.12 seconds, correct? The whole entire QRS complex. So each small bound is what? 0.04. So how much is the less than? 0.08, correct? So is it less than 0.12 seconds? Yes. Some abnormalities, though, usually when we're dealing with potassium imbalances, can cause the QRS to be either wide or narrow. Okay, so remember, it's time. It's time that it takes for ventricular contraction to occur. So ventricular contraction can either be long or short. Okay? And of course, the longer it is, then it doesn't really matter whether it's long or short. What happens to cardiac output? It will drop. Let's go now to the next wave, which is the ST segment. This short segment here, S to T. What does ST segment represent? Ms. Peguero?
It is analyzed to identify whether it is above or below the isoelectric line, which may be among others, the sign of cardiac.
Okay. So it's another chapter. So chapter 23 will be next semester, acute coronary symptoms. For can I bring a marker? So the ST segment is usually isoelectric, meaning flat. Supposed to be flat. For ischemia conditions, so for example, when we have ST elevation, that means the S won't reach here, the S will be seen here and up here like that. So it'll be like this. Okay, so this is what we call ST elevation. So what happens, this appears when, let's say, this is your heart. Someone has a heart attack. It's a ST elevation MI, meaning like this, ST elevation. So that means it indicates the entire thickness of a patient's heart muscle died. So the blood clot that caused the heart attack caused actual death of the heart muscle. An entire thickness died. So because of this, the ST segment would appear like this. So think of it as these cells, will they ever repolarize? They're dead. They can't repolarize. So this is the cell. And when we say depolarize, that means it's full of positively charged particles, calcium, potassium, and it will depolarize, meaning discharge. So after depolarization, they will look like this. They're all negative, right? So this is a resting cell. And then they start to repolarize when they start becoming positive again, ready for the next contraction. Since they cannot do this, these cells here cannot do it. Only these cells here are still alive, so they will show early repolarization right here. Okay. Whereas if, let's say, you have another type of heart attack, wherein instead of ST elevation, you'll have something like this, which is ST depression instead. Actually, it will look more like this. Okay. This is now ST, non-ST elevation MI. So this means that it's still a heart attack. However, it's not transmural like this. This is transmural. So this is what we call a subendocardial heart attack. It's still a heart attack. It killed some thickness of the muscle. However, it did not kill all of them. So these things here are still alive. Okay, remember the electrical conduction cells, cells working is all because of ATP, correct? So therefore, these guys here, do they have ATP? Zero ATP. Okay, so that results in this. This one, these guys here are still alive. They still receive ATP, meaning, yes, the patient suffered a heart attack, but somehow during the whole episode, blood flow was restored, allowing these guys to still receive blood flow, meaning the heart attack happened already. It killed some, but the killing stopped. You follow? So therefore, which one will require immediate intervention? This one or this one?
That one.
This one will require immediate intervention because this will not stop. This will not stop here. This will kill more, right? This one, did the ischemia continue?
No.
Not anymore. So yes, it happened. The ischemia happened. The heart attack happened, but the blood flow somehow was restored. So there's nothing we can do. This is already dead. But since the rest are still receiving blood flow now, so the therapy here can wait. So we have time for this type of heart attack, the NSTEMI. You have about 6 hours. Sometimes we wait till we'll do it tomorrow, something like that. And this one, like right now, the patient needs to go to the cath lab. Otherwise, this patient will die unless we restore blood flow to the rest. All right. So that's the significance of the ST segment. So it indicates myocardial ischemia. Yes.
I don't think she died. But when I called 911, they told me she had
ST elevation. Oh yeah, good job. We won't know unless, yeah, probably, yeah, she had STEMI. So she had this time. And usually, if it's an acute MI, you'll have not only the ST elevation, but you'll have, since they died, so will they repolarize? No. So instead of a positive T wave, this positive means you're repolarizing, right? Since they're dead, can't repolarize, you have T wave inversion instead. So that's the, let's look at the last one, which is the T wave. What does T wave represent? Mr. Mario Adler?
It follows the QRS complex and is usually the same direction as the QRS. Visual repolarization also occurs, but is not visible in the EKG because it occurs at the same time as visual.
So all that's saying is, as we already talked about, so the T wave is basically the ventricles, the myocardial cells in the ventricles starting to become like this again. So after depolarization, they were all negative, right? Then now they're starting to become positively charged again in preparation for the next depolarization. So they're simply trying to prepare for the next QRS complex. All right. And as I mentioned, the U wave, it's not really that significant. We only see them in, not all patients with hypokalemia will show the U wave. Sometimes it's there, sometimes it's not. Okay, and particularly you see it appears with hypokalemia, but I don't see it all the time. Sometimes it happens, I mean, it shows up. Most of the time, no, not at all. Any questions about the waves and complexes? So when you see this on a monitor, do you know now what's happening with every wave and complex? Okay, so do we want to see P waves? Yes, we want that P wave to be there all the time. Then PR interval, and then QRS, etc. Okay, let's go now to the steps. So first thing we need to know when we're looking at a cardiac strip, the first step is always counting the heart rate. There's a box here, chart 22-1, that tells you the order, the steps you need to do to determine, to analyze a rhythm strip. I won't follow these steps because for me, it doesn't make any sense because they go from ventricular rate. It should really be the atria first, correct? Okay, it's not in the proper order. So after the heart rate reading, my next step would be the P wave. Okay, I prefer to look at the P wave because why would I go to the QRS and skip the P wave, right? And skip the PR interval. Does that make sense? Okay, so it doesn't really matter what order, but if you want to be organized, systematic, I would go with the P wave first. I would go with P wave, PR interval, and then QRS, just like what we did earlier. Okay, I prefer to do it that way. So since regardless of the textbook, the first step is always the heart rate. So let's look at the different methods we can use in order to count the heart rate. So let's use this as an example. Now, regardless of the method you use, and I don't know what method you guys will use, you're always free to use whatever method. It's just a matter of choice. Now, a 6-second strip usually is about this long on an actual paper. So it's about this long. Okay, that's a 6-second strip. So how long will a 60-second strip be? You need 10 of these. If I have 10 of these, do I have room here? You have room on a table at the nurse's station? Do you have room on your cow? No. So is it practical to analyze a 60-second strip? No. It's a waste of time. It's not practical. So we only need 6 seconds. Then we multiply that by 10. There's our 1 minute. All of these methods, by the way, are estimates. It can't be accurate because the only accurate heart rate is if you do a 1 minute strip. Then yes, that's accurate because you literally counted a full minute strip. But again, is that practical? You won't have time for anything else. Now you're going to be busy. So we're not using a 1 minute strip. We only use 6 seconds. So how do we know a strip is 6 seconds? Now on a real paper, you'll have 3-second markers. They'll appear on top. 3 seconds. That's just an estimate, but let's mark our own 6-second strip. So how long is one big box? If one small box is 0.04, so how long is one big box? 0.2. So 1 second will have how many boxes? 1 divided by 0.2. 5, right? So every fifth big box is 1 second. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. So this is 3 seconds right there. Got it? Okay, so let's draw another 15. Okay, that's fine. Another 3-second marker. So now do I have 6 seconds? Yes, I have 6 seconds. So I'll count from here to here. The easiest way is what? Because I know 1 PQRST is 1 heartbeat, correct? So can I just count the PQRSTs within that 6-second strip?
Yeah.
Can I count this one?
No.
Why not?
Because you can't see the P.
Is this a complete heart rate?
No.
No, it's missing the P, right?
Yes.
Okay, so can I count this one?
Yes.
Okay, let's count. 1, 2, 3, 4, 5, 6, 7, 8. Is it exactly 8? Yes. Yes. So do I say this is 80?
Yes.
It's not,
No.
because remember, this is part of a heartbeat. This is 3/4 of a heartbeat. So is this really 80? What is it? 80 something, right?
Yeah.
We know it's between 80 and 90. Can you say it is 90?
No.
No. So on a test question, if I give you this strip, what will be the choices you'll see, A, B, C, D? Will it be a definite rate or a range?
Range.
I'll give you a range. So I'll say A, 60 to 70. B, 70 to 80. C, 80 to 90. D, 90 to 100. C, 80 to 90. Got it?
Yeah.
Okay. So don't worry, because this is again an estimate. Nothing is accurate here because is this ever going to be accurate? No, because this is only 6 seconds. I need an entire 60 seconds for it to be accurate. Are we clear? All right. So that's one method. I mean, it's all estimates, right? Meaning this one is not really a complete heartbeat either, correct? Because it's the T wave actually ends here, right? But this one is part of a heartbeat, right? So if you move everything, that still gives you about 80 something. Yeah? Okay. So the next method, you can look at your textbook on the determining heart rate section. So it tells you to count small boxes or big box. So if one small box is 0.04 seconds, so how many small boxes are there in 60 seconds? How many? 60 divided by 0.04. There are 1,500 what? Big or small boxes? Small box. How about big box? One big box is how many seconds? How many? 300. 300 big boxes in 1 minute, right? Okay. So, the book tells you you can count the small and big boxes between 2 consecutive waves. You can choose any 2 waves. 2 P's, 2 R's, 2 T's. Which wave do you want to count? Most people like the R because the R is nice and pointy. All right. So I'll use the R, just like everybody else. Which 2 R's do you want to count?
The R's?
Any 2 R's. If I were to pick, I would choose this R or this R. Why? Why would I choose these 2?
Because they look the same.
Because they fall on a straight line. So it's easy for me. So if I count between these 2, can I count the small boxes or big boxes between these 2? Very easy. So how many small boxes between these 2? 5, 10, 15, 16, 17. It's not really 17 because it's somewhere in the middle. It's more like 17 and a half, correct? Okay, so 17 and a half small boxes. How many small boxes in 1 minute? We just did it earlier. How many small boxes? 1,500. So 1,500 divided by 17.5 is that. 85. Is it any different from your estimate earlier when you counted the QRSs, the QRSTs?
No.
The same, right? 80
Yes,
something.
between.
Let's do big boxes now. Pick any 2 R waves, Miss Butina. This one? This one? Which one? This one? Okay, this one to this one, right? These 2. Okay. So how many big boxes are there between here? Big box. 1, 2, 3, and is it really 3? Exactly 3?
No.
No. So if you move it, it's about 3.5, correct? So if you move this here to the straight line, move it, so that brings you to about 3.5, correct? So how many big boxes in 1 minute? Go ahead. How many big boxes in 1 minute? 300. Divide that into 300. What you got? 85. Okay. So on the exam again, I don't know and I don't care which method you use. Which method you use, you want to count the PQRSTs in a 6-second strip. Count the small boxes between 2 R waves. Count big boxes between 2 R waves. I don't care. You will still arrive at same number. However, this method, all these methods we talk about, the 3 ways to count the heart rate, will only work if the rhythm is regular. What do I mean by rhythm is regular? That means, are the waves and complexes occurring about the same time? Now, to do this, we really need a caliper. Calipers cost anywhere between $3 to $10, depending on the brand you buy. But here is a poor man's caliper. Just grab any piece of paper. And I'll mark 2 waves. So let's say I mark this P wave here and this P wave. And see, is it occurring regularly? Is it?
Yeah.
Is it?
Yeah.
Yeah. Yes. Yeah. So let's say, what about the R wave? Okay, let's see. At those 2 R's and then the next 2 R's, are they occurring?
Yeah.
Yes, they are. Yeah. So what can you say about this strip's rhythm? Is it regular?
Yeah.
It's regular. So can I use any of the 3 methods I use?
Yeah.
Yes. It's going to be a little difficult if the rhythm is irregular. However, do not worry, because if it's an irregular rhythm, will the heart rate be the same from 1 minute to the next minute? It won't be the same anyway, correct? So it's still going to be an estimate. Are we clear?
Yes.
However, don't worry, all our equipment, as long as you have working equipment, the monitor machine will give you an estimated heart rate. Okay, you don't have to count it. Okay. Any questions about counting the heart rate? Go ahead. No. I didn't mean I divided that. 60 divided, no, it's the other way around actually. 60 divided by 0.2, 60 divided by 0.04. Then the next step is are there P waves here in this rhythm? This strip, are there P waves? Yes, we have P waves. Okay, each one has a P wave. Are the is the PR interval between 0.12 to 0.2 seconds? The PR interval is from here to here. Is it between 3 to 5 small boxes? That's 3 plus 1.5. Yeah? Okay, so it's between 3 and 5 small boxes. You can do the same for the succeeding ones. I'm sure it'll be the same. Next is the QRS complex within 0.12 seconds. Is it within 3 small boxes? Yes. Is the SD segment isoelectric? Pretty much. Okay. You won't see it here because again, this is a illustration. Okay, it'll be better on an actual rhythm strip. Is the T wave positive? Yes. So if they meet all those measurements, then they meet the characteristics of a normal sinus rhythm, which is on the next page. Let me finish with this Q7 alert first. Now, regardless of what the monitor says, who do you assess first? The machine or the patient? Always look at the patient. No matter what the monitor says or tells you, go look at your patient first. Run to the room, look at the patient. How is the patient tolerating the dysrhythmia? Are we clear? Okay, so don't go focusing on the machine. You see the rhythm, abnormal rhythm, and then everybody go analyze it. No, what do you do first? Go look at your patient, okay? Regardless, we can look at the monitor later. Look at your patient first, okay? Because you need to know whether your patient is tolerating the rhythm or not. Okay, you check the pulse, check vital signs, check mental status. Are we clear? All right. So let's look at this alert here. Let's talk about alarms. Now, some patients will have abnormal rhythms regardless. They'll stay with abnormal. Perfect example is atrial fibrillation. Patients will have chronic AFib. They'll never have a normal sinus rhythm. Okay, so therefore, will the machine ever stop alarming? No. So in that case, for instance, so you're going, that is what it's saying, that the nurse will assess the patient's monitor and then adjust the alarm default setting, because of course the default setting is the normal heart rate is between 60 to 100, right? So if this patient is consistently around 55, 56, will this ever stop alarming? It'll keep alarming. So therefore, and as long as you assess the patient, they're fine. They have no symptoms whatsoever. Blood pressure is normal on that heart rate. So therefore, can I adjust the parameter for the alarm? Yes, I'll lower it to maybe 55, right? So I'll just say instead of 60, I'll put it at 55. So anything less than 55, the alarm will go off. Does that make sense?
Yeah.
Then you can also do the same for the upper. Okay. And that's the same also for a CPAP, a BiPAP. All right, so that you don't go crazy, because what will this do? Remember the story of the boy who cried wolf? What did the boy do? I mean, what did the villagers do after the boy cried wolf 5, 6 times? They ignored it, right?
Yeah.
So same thing, what will the nurse do? If this is constantly happening, beeping, and then you go there, she's fine, blood pressure is normal. So what will you do? Ignore it, right? So that one, same story. What happened when there was really a wolf? What happened to the boy? They lost the sheep, right? So therefore, what would happen here? You keep ignoring, patient might be dead. Okay, then you had no idea, because same story as the boy who cried wolf. So normal sinus rhythm, these are the characteristics. So if they meet these rates between 60 to 100, rhythm, when we say regular again, what does that mean? That the waves and complexes are occurring at the same intervals. Waves and complexes are normal. P wave look the same, appear normal. QRS the same, PR interval within 0.12 to 0.2 seconds. ST segment is isoelectric, T wave is positive deflection. All right, so that's normal sinus rhythm. So on the test question, can I use this rhythm strip? Yes, because I said I use one that is on your textbook, correct? What about the one on the previous page? Is this normal sinus rhythm? Yes, this is also normal sinus rhythm. Get it? All right.